And today the monthly program of the VITILIGO Center Climate Change in Neuroscience and Lakeside Education Trust and International Pediatric Association. I think we just want to highlight what is the International Pediatric. First time it is started. It is head office situated in Switzerland. It represents 1 million pediatricians in 150 countries. Recently, they had in Athens executive committee meeting. There they selected as a co-chairman for the climate change and environmental issues to make a module to train all the doctors across the country, across the world. I am the person nominated for that one. So I had the pleasure of the permission, including them. They want this education program. And also next time onwards, we are going to spread all over the world. And your record will go to all over the world, madam. So we are recording with your permission. And today's program is also vitiligo, a skin disorder at the crossroads. And we have an expert who is going to speak about here. I request Professor J. Srinivasan, and he the founder of this institution. Is a man with words, scientific, and the way you can learn, the way they ask question, he find out small point in no time. And we learn each other a great deal, matter of fact. And he has done COP, many of the COP 26, 27, 24, 25, 15th also. He's an editorial board of that. And in addition to that, he's a man with words. What he preaches, he practices. Why I say that in carbon footprint, reducing the carbon footprint, even though we produce 1.3 to less than 2 in India, all over the world, America produces higher. Usually 4 ton of carbon footprint we have to reduce. They recommended 2. Each person should reduce carbon for 2. He's been walking from here to Malleshwaram home. He walks back to here, and inside sometimes he uses bicycle. And shopping he goes that one. And all these things consider nearly 4 tons of carbon footprint. He produces more than what recommended by the international. Here is a man with words. We feel very proud of him. And I request him to the dais and to formally welcome all the people. Thank you, sir.
Good afternoon. Thank you, Dr. Parmesh. All of you are aware of this monthly seminar that's held on various issues related to health, which Dr. Parmesh has been doing for the last 3 years, right now. And normally we hold it on last Thursday of the month, but this last Thursday this time is a holiday, so we have meeting on a Tuesday, and we are taking a look at a new topic related to a skin disorder, which causes a lot of psychological problems for many people. And so I'm very happy that Dr. Parmesh invited an eminent doctor, Dr. Sumati, to talk to us about it. And so I request Dr. Parmesh to introduce the speaker.
I think, as you know, vitiligo is a chronic skin disorder that causes patches of skin lose the pigment or color. This occurs when pigment-producing cells in the skin, those are called melanocytes, are attacked and destroyed, causing the skin in the form of milky white color. And it is the magnitude of the problem globally is 0.5 to nearly to the 3%. Yes, nearly 3%. And it is more visible in a people with a darker skin tones and develop at any age, but apparent before the age of 30 years. And it is a non-contagious lifelong condition with no specific cure. It has significant psychosocial comorbidities needing multidisciplinary approach strategy to educate the people. To talk about this important topic this is the month of the vitiligo, we have none other than one of the doctor of very well known in the country and here. Dr. T.K. Sumati, she is MD, MNAMS, and the senior professor of HOD of Department of Dermatology, Ramaya Medical College, Bangalore, senior consultant at Ramaya Memorial Hospital also, which is adjacent to our building. She is a PG teacher and examiner since 22 years, a paper setter for various universities in the country. Principal investigated more than 40 clinical trials she had, one of which has been audited successfully by the FDA, Federal Drug Administration, and published several scientific papers in peer-reviewed journal, authored several chapters in dermatology textbooks, a former member of the Ethics Committee of the Ramaya Medical College. She is the chairman of the Medical Audit Committee of Ramaya Medical College, member of Transplant Committee in MS Ramaya Medical Hospital, a senior lead auditor for the ISO standards. A special interest include clinical dermatology, especially pediatric dermatology and pimples and all this and other thing. What you are asking, she's an expert in that. If you go to the internet, you see she's a pimple expert and acne expert, all the skin problem expert. So without wasting our time, I had a great pleasure extending invitation to Dr. Sumati. Take over.
Good afternoon to you all. Am I audible? It's okay? I'm very happy, in fact, privileged to be here today. And I must thank Dr. Parmesh and Dr. Srinivasan for having given me this opportunity to address, especially I see a lot of young people here. They are my favorite audience at all times. And the topic of today is a very interesting topic. It's a little mysterious, all the more necessary for countries like India because we are people of color. And people of color, when they are affected with these kind of white looking patches, it reduces the self-esteem of people. So let us go directly to that. Now the month of June, as Professor Parmesh said, is the month of vitiligo. In fact, there are two dates of importance in this month. The first one is the 13th of June, which is celebrated as the World Albinism Day, Albinism Awareness Day. And albinism differs from vitiligo. I am sure you all know. If you don't, I'll just tell you in a few words. Albinos or albinism, you should not call them albinos. Albinism is a condition where they have the cells called melanocytes, but those don't produce melanin. And they don't produce melanin because of some enzymatic defects which are congenital. So they not only affect the skin, they also affected all the melanocyte producing parts of the body, which include the eye, the hair. So if you have seen albinism people on the roads, you will see that they have photophobia. They just cannot open their eyes because their eyes, pigment in the eyes are also involved with the loss of color. And hence they're very sensitive to sunlight. I'm sure you will remember seeing people who are always closing and they have red looking eyes because the pigment is not there. So that is albinism. So 13th of June is the World Albinism Day, whereas 25th of June is celebrated as the World Vitiligo Awareness Day. Now, vitiligo, as Sir was telling, is by far the most common acquired pigmentary disorder on earth. It affects 0.5 to 2.88% of the world population. And among these, the geographic centers where there is a high prevalence include India. Actually, India has the highest incidence of vitiligo, highest prevalence of vitiligo, that is 8.8%. And next is Mexico, which is exactly half, 4%. Now, why are we discussing the disease? This picture will tell it all. You see, the left picture is of a white person with vitiligo. The exact same topography on the right side in a dark colored individual. I'm sure if you see a person on the road or at work, you will notice the right person definitely much more than the left. So because of this contrast in races of color, we call it as Fitzpatrick, 4, 5, this kind of skin, it becomes very noticeable, especially because it is speckled. If it was uniformly discolored and the people are totally white, they wouldn't mind at all. In fact, many of my patients have become like that naturally after many years by themselves. And today they're very happy. So we look beautiful because they're fully white. So I have a couple of patients. I'll show you one or two pictures. So therefore, this contrast is the one which makes it, very, dismaying for the patient and for whoever sees. In fact, our postgraduates, when they join newly, they do the moment they see a patient. I said, no, you're not to do this. You're not to do this at all. Imagine what the person will feel. I mean, these people are new. They don't know anything about it. The postgraduates as they come to dermatology. Because in undergraduate studies, dermatology is not dealt with that much. So therefore, so you can imagine how the society at large feels about the disease. So therefore, I just put up this for you to know the difference. And then therefore, again, vitiligo is devastating psychologically. Patients feel stigmatized. And why do they feel stigmatized? Because there's a simile to the infectious disorder leprosy. This was very much in the past. Nowadays, people know that leprosy is not like this. But for people, say from rural backgrounds, they have no knowledge at all, illiterate people, they may think this person has got an infectious disease and therefore we should not shake hands with them. We should not be standing close to them, and this is due to some kind of a curse and all that. So literature talks a lot about this, and there's mention of this even in our Vedas. Okay, so there is a mention of leprosy, mention of vitiligo. They did not know one from the other those days. So the people they feel stigmatized, they have a poor body image, and they cannot come up to their best because of this. They have low self-esteem. And the impact on the quality of life is pretty significant. So what is happening, as sir already said, there's absence of pigment in the skin. And this is due to loss of the cells themselves, not the pigment, but the loss of the cell itself. So loss of melanocytes. This is the way in which it differs from albinism. Okay. Now, where do we find these melanocytes? People may think we find it only in the skin, but we find it in the eyes. I told you just now. You can, of course, find it in the hair. That's why we have the color. And inner ear, bones, heart, and brain. All these they are derived from what we call as the epidermal counterpart in the embryo, the growing embryo. So embryo, the epidermal part is not only the skin, it goes to form part of the bones, the heart, the ear, and the brain. So, and these form melanin. Now, what does melanin do? Melanin has got capacity to quench the oxidative stress caused by sunlight. And in that way, it prevents the damage to the skin. And that is why the whites have a big problem with sunlight, and that is why they tend to develop malignant melanomas, squamous cell cancer, and basal cell cancer, which is quite rare in the Indian skin if you were to compare. And we are protected by our color, and we want to become fairer and whiter. Actually, we are the ones who are protected. We have all the safety within us. In fact, in all my 30 years of practice, I must have seen just a handful of malignant melanoma. Whereas we have huge textbooks written on malignant melanoma in the West. Okay, so this is the benefit that melanin does to us. If you do a histopathology of our human skin, you will find this melanin in all the layers, starting from the lowermost layer to the uppermost layer. Whereas in the whites, you will find it only in the lowest one layer. And in the Africans, you will find it through and through in huge globules of melanin. And that is why they have that color and they hardly ever develop melanomas. So what is the pathogenesis of vitiligo? So it's a multifactorial one. There's a genetic predisposition, definitely, which many families are concerned about. They want to know, they ask us the questions. And there is autoimmunity. It is now known to be definitely an autoimmune disorder. Okay. And the last one is there are environmental factors that can influence vitiligo. Now coming to genetic, it is seen in our country 20 to 30% familial incidence of vitiligo is there. So we always ask the family history, whether somebody in the family has. We ask them to go back at least 2 or 3 generations. Sometimes it may skip one generation. And it is seen in monozygotic twins. So this is one proof that this has got a genetic predisposition. Autoimmunity. Over the past decade, studies have clearly established that vitiligo is an autoimmune disease, which are mediated by CD8 positive T cells. And these secrete interferon gamma. Interferon gamma is the one which induces several chemokines to be secreted from the skin cells, and they are the keratinocytes. The rest of the cells in the skin are called keratinocytes, and so we have keratinocytes and melanocytes. These keratinocytes are the ones which actually mediate all these chemical markers, inflammatory markers, and produce the autoimmune reaction and destroy the melanocytes. So treatments that actually block the interferon gamma signaling can actually reverse vitiligo, but it has been found that there is relapse on stopping the treatment. This is because of the resident memory T cells, which do not forget. They don't forget at all. So they'll attack the moment the autoimmune process occurs. Now, what is the role of the environment? So for this today's topic and in this hall, it's important to know what is the role of the environment. Whether vitiligo is induced by chemicals is actually a moot question, but there is an entity called chemical vitiligo. So this is caused by, which has been recognized for more than 75 years now. Previously, we used, when I was a undergraduate student, we knew that certain industries is an occupational hazard. So those industries we knew very well were rubber industry, plastic industry. These two industries were known to have people who are working there who develop vitiligo, who develop depigmentation, especially wherever they are working, whichever part of the body they are handling, usually the hands. So I myself have treated quite a few people, and then I have given them a change of scene in the factory itself, and many of them the colors have come back. So that is one thing. And but now this is now seen to occur with household products also. Even detergents can cause, and certain colors which are used commonly in the house, like kumkum, can cause. I'll just come to that. So some of these are so popular that we have used it to depigment the remaining skin. I told you about vitiligo, which is extensive. So we can depigment the remaining skin using these chemicals, especially the monobenzene of hydroquinone. That particular molecule can depigment. So we use it for therapeutic advantage. So I'm not sure whether you knew that hair dye can induce vitiligo. Paraphenylene diamine is a chemical which can induce vitiligo. And how do we recognize it? It is there at the borders of the scalp, hair margin. So that tells us, and of course throughout the scalp. Scalp we cannot see because they have the black hair with the dye on. But you can look at the hair margin and then diagnose this person probably has. Especially in men, they use it on the mustache or the beard too. So those areas also depigment. I have a picture I'll show you. So detergents containing 4 tertiary butyl phenol and amyl phenol can also induce depigmentation. Alta, many of you know what Alta is, worn by the northeast and the eastern part of India. The married women apply that on their feet. Pinkish red colored dye. So that signifies the marriedhood, like how we have kumkum in the south. So there they found that exactly on the border of the Alta, the patients began to develop vitiligo. So then they traced it to, in fact, the pioneering research in this was done by an Indian, Professor A.K. Bajaj. Had the good fortune to meet him. He is now in his 90s. He has written books and books on this. He was the first one to recognize this alpha-induced depigmentation. And that is caused by rhodamine, B, and crocin, scarlet, MOO. These are the dyes. And insecticides can cause, rubber and plastic footwear, as I told you, and colored toothpaste can also cause vitiligo. But there's one good thing. In our practice, we have seen this occurring in people who are a little predisposed to vitiligo. Not everybody develops, except those strong chemicals I mentioned to you in the beginning. That is the ones used in rubber, antioxidants in rubber industry and plastic industry. They can cause, and whoever comes in contact with them for a long period. And paint industry too. That's probably because of the dyes. But in these other things like, colored toothpaste, Alta, they must be genetically predisposed to it. If you watch carefully, you'll find vitiligo of the normal type somewhere hiding in the body. So that is a clue. So how do these chemicals do that? They are toxic to melanocytes because they compete with the tyrosine, which is required for melanogenesis. So these are the pictures. You can see on the left, there's the lady, she is using the bindi, the kumkum, liquid kumkum. So that could have induced the depigmentation there. But again, she's using a hair dye too. So we can't be very sure whether this has caused or that has caused. We can do a patch test where we apply the same chemicals into the inner arm and keep it on for many days. Vitiligo doesn't appear overnight. It will appear maybe after a month. But that will prove that this agent has caused the problem in that patient. So the left one is kumkum induced or hair dye induced depigmentation. The right one is what I spoke to you about, mustache and beard area, hair dye. Is exactly following the shape of the hair dye application. Now this is regarding footwear, maybe rubber or plastic. This young person has used the footwear and you can see the bilaterally symmetrical appearance exactly where the strap of the footwear rests. Okay, so these are the clues. Now what are the associated disorders? Vitiligo is not a disorder of the skin alone. So there are several disorders in the skin as well as in the system which are associated with vitiligo. So all these disorders are autoimmune by themselves. For example, if you see the skin disorders, you have diseases like alopecia areata. Alopecia areata is patchy loss of hair, usually seen in children, but adults too. It's a chronic disorder where the hair produces immune antibodies to its own self. So that is an autoimmune cause of alopecia areata. The second one, of course, you know, psoriasis, eczema, and lichen planus. All these are autoimmune disorders. They have a 2 to 3-fold likelihood of developing vitiligo. Okay. And systemic disorders such as hypo and hyperthyroidism, especially the thyroid tissue, can induce both the hypo and hyper forms can induce vitiligo. So the first history we take up, postgraduates take in their pro forma when they're doing thesis on vitiligo is whether there's a history of hyperthyroidism or hypothyroidism in the patient. So many times you do find that, and especially thyroiditis of the autoimmune variety. There's something called as Hashimoto's autoimmune thyroiditis that is known to be associated to a great extent with vitiligo. Diabetes mellitus, of course, they have 5-fold increased chance of developing vitiligo. And pernicious anemia is again an autoimmune disorder. So that is associated with vitiligo and gastritis too. How do the patches look? We all know that the pearly white, they're depigmented totally. Of course, when they're developing newly, they'll be hypopigmented, not totally D. And after some time, they become depigmented. They have a tendency to enlarge centrifugally. Okay? And the most common sites, unfortunately, are the hands, feet, and face, which are visible to everybody. So that is the quantum of issues the patients have. And they have a peri-orificial predominance. We see very commonly around the genitalia, especially in young children, and around the mouth, on the lips. These are the places where you develop. And we can broadly classify them into localized one and generalized one. Generalized one, of course, most of the body parts can be involved. There we have something called acrofacial, the one which involves the face and tips. That's called acrofacial, the extremities of the body. And you have what's called the lip tip variety, which involves only the tip of the fingers and the lips. These are particularly difficult to heal because the color has to come from hair follicles. The donation is always from the hair follicle melanocytes because there are plenty there compared to normal skin. And there are no hair on the lips or the tips of the digits for men or women alike. So therefore, it's very difficult to treat such patients of lip tip variety. Now, coming to the localized ones, we have what's called a segmental, which involves only just one segment of the body. It doesn't cross the midline. Something like herpes, location-wise. It can be on the face, on the neck, or on the trunk, but usually doesn't cross the midline and commonly seen in children. Prognosis is not too good because it doesn't respond to treatment well. They respond well to surgery. So I'll just show you the pictures. And then we can have mucosa, people having only inside the mouth, on the lips inside the mouth. And then you can have what's called as focal, anywhere in the body, but remaining there for a long time. Now these are the pictures of segmental vitiligo. So you can see that they don't cross the midline. And the peculiarity is wherever the hair is there, those areas are also whitened. So the hair become gray or white. They lose their pigment. That's called as poliosis. So treatment is difficult again because when the hair itself is the donating area and that has no color, the prognosis is not very good. So you can see the eyelashes, eyelids, the eyelashes as well as the eyebrows in the young person. And on the right, you can see some pigmentation, something is going on there, some improvement is there. Now this is what has occurred in this child and good response to treatment. Children respond normally very well, provided it is not segmental. This is not segmental because you can see it across the midline. Okay, it's going to the left side of the face also. This is the lip tip variety. These are generalized vitiligos, extensive vitiligos. The patient on the right, you can see pigmentation occurring very well. This is actually a very good response. This response can occur on the very right, last one. This can occur spontaneously by just going to sunlight, or it can occur following phototherapy treatment. So what phototherapy does, or what the natural photo does, the sunlight does, is to stimulate the hair follicles to release more and more melanin from their melanocytes into the skin. And for men and women, neck is hairy, although it doesn't look. They are very fine hair, brownish colored hair called as vellus hair on these areas, but they are able to pigment. And so after another few months, this will be totally, you can just not see those patches. This is what I was talking to you about universal vitiligo, person who has lost the entire color. But you can see some blackish spots, that is where the skin is trying to repigment naturally with 1 or 2 for the normal areas left. So they'll come to us to get those removed, see, for better acceptance. So this is called as universal vitiligo. Now what happens in the disease is very unpredictable, uncertain. Usually it shows a very slow progression. Okay, so it may remain static for years together and suddenly decide to go away very rarely or increase. And episodic increase can occur in number and size, even after many years. So complete spontaneous cure is extremely rare. So what do we do? What are our goals in treatment with so much of, really the adversary is very strong. So what do we do? The treatment goal will be to at least slow down the disease progression, to induce the repigmentation with treatment and hold on to it to prevent the relapse. What are the methods we have currently? We have things which are non-targeted and targeted. Targeted means with recent advances at the molecular level, we know what's happening. So there are some medications which have been made to target the actual etiopathogenesis, what is happening at molecular level. Now the non-targeted ones are the very popular ones because they have been in use since decades. So we have been using topical and systemic corticosteroids. Corticosteroids have the capacity to be, they have 2 ways how they act. They are anti-inflammatory and they are immune suppressant. So in that way, they are ideal for any autoimmune disease. So what they do is they prevent the reaction of the body, those chemokines production and all that, of course, temporarily, so the skin can pigment back. Systemic corticosteroids are usually not given. We only give systemic corticosteroids when there's a rapid spread of vitiligo. Vitiligo spreading within a few weeks or months, and then we need to really, curtail the spread. In such cases, for maybe a few months or maybe up to a year, we do what's called as pulse therapy, which instead of giving every day, we give it once a week in a bolus dose. So this kind of a dosing reduces the side effects, but is able to do the job. Pigmentation, depigmentation can be stopped. So the progression can be stopped. However, we don't need to use corticosteroids alone nowadays. We can use what is called as non-corticosteroid immune modulatory agents. Some drugs like methotrexate, drugs like azathioprine, and such drugs as cyclosporine. All these are available, but then again, they need to be used by experienced people. Experienced dermatologists have to use them. Patients should be very compliant. Now, topical non-steroidal immunomodulators. These are again very useful, especially in children, because their side effect profile is very good. So they use what is called a tacrolimus or pimicrolimus. These 2 drugs and calcipotriol. There are 3 drugs in that armamentarium which are non-steroidal, which can be used even on faces, delicate places like the eyelid and the rest of the face. And we do phototherapy. Phototherapy is extremely popular and very doable, and they can use the sunlight itself in our country without much cost, or they can come to phototherapy chambers. I'll just show you that chamber. This is the phototherapy chamber we have. We have these chambers in both the hospital, the old hospital, what we're teaching hospital, as well as the memorial hospital. Person has to go into these chambers, and it's computerized. The level of energy which goes into the skin is pre-programmed, and they have to stay for about starting from 5 minutes to about 20 minutes later on. So these are UV chambers, UV lights, which have a specific effect of an anti-inflammatory and local immune suppressant action without side effects, however. And it can be safely used, except that the eyes have to be protected. That's it. Even pregnant women and young children can use this. So this is phototherapy. Then surgical modalities are there for certain kind of cases where you have very localized vitiligo, where you have in places which are difficult to treat, like the tips of the digits, ankles which don't pigment with any treatment. Such cases you can do, provided patient is not in active vitiligo. At least a year has to pass by when the patient is stable regarding the disease, and then patients can go through with this. Now, targeted ones are very interesting. We have this JK inhibitors, the Janus kinase inhibitors, are called JAK-STAT inhibitors. So they're holding great promise, and there are 3 of them. One is ruxolitinib, then tofacitinib, and baricitinib. So these 3 drugs are not on trial exactly. They have been used, but then long-term effects, long-term benefits we have to see. Now, other drugs, these are just in the pipeline. They're noted there. Stimulation of melanocytic stem cells is an interesting topic. So surgical modality, as I already told you, what are the methods we do? We do what's called as punch grafting, where small bits of skin, 2 millimeters or 1.5 millimeter, large such number of patches, grafts are taken from normal skin, pigmented skin in covered areas where the person won't miss them. They're taken and applied to pits already made in the vitiligo skin. They're inserted there. Especially if they have hair, is beneficial because they'll get better pigmentation. So this is called as punch grafting. They are mini punch grafts. So otherwise we do what's called a suction blister. I'll show you the picture of that. This is a suction blister patient. The patient had lip vitiligo. We have induced a blister formation in the patient's forearm using negative pressure, using a vacuum, using a syringe. The syringe is placed like that for about at least an hour, and then it makes a bubble like this. So the blister is formed on top. It looks a little grotesque, but because it's close up. So the blister roof is grafted, and that skin contains active melanocytes, which can be then applied on the lip after the lip area is dermabraded. We abrade the skin manually or electrically or by laser. So a wound is made, and this blister is placed on that, and a tight dressing applied for about 10 days. That is the result. Immediate, maybe a week after we have removed it, this person is fully okay now. The only problem is you have to match the color of the lip. You should exactly match that area. Mostly men don't bother, but women have an issue. So they are particular about it. So that is the only thing. But however, they are happy that the white patches are not seen. Okay, so that's it. And we can also use cultured and non-cultured skin material. For example, epidermal material can be used, crushed and applied on the abraded skin. That's called as non-cultured epidermal suspension. Or you can grow the melanocytes in the lab culture and introduce them on the abraded skin. The best part is you use very little melanocytes and you get response to large areas of the body. But the culture is not easy. It's quite intensive in the procedure in the lab. So results are good. So this brings me to the end of today's topic. I've tried to deal with the disease, with the significance of the disease, and a little bit of helplessness, but many patients, when they come back with good response, we are happy, and that motivates us. And finally, the surgical modalities. If anybody has any doubt they want to ask, they can ask. She has a yeah.
Is there any link to deficiency naturally within the body that can aggravate condition, like vitamin D deficiency?
Phototherapy is actually done only to stimulate the good melanocytes to produce melanin and donate. It is not connected at all to vitamin D deficiency. And vitamin D deficiency is now the rage. For any and every disease, vitamin D is added. So we really are not very sure that vitamin D. Anyway, vitamin D deficiency causing vitiligo is not mentioned in literature anyway.
Any reason why India has the highest rate in the world?
Possibility I feel is that this intermarrying, the consanguineous marriages, and therefore the incidence of all these genetic disorders increase. That could be one of the reasons.
Then it should go down in South India than North India, right?
Possibly. See, the other thing is South Indians are more aware. They may come for treatment earlier. This is what we have seen. But the literature, the percentage that I spoke to you, all pan-India. So maybe better studies will come through. We can see whether it is more common in South India. And we are being of the darker shade. It's again more noticeable patients will come for treatment. That's another reason. Yes.
This probably is not.
Well, Mexicans have both types of skin. They are not actually white. They have Fitzpatrick 2 to 3 coming towards the Asian side, may not exactly like them, like us, because the indigenous people there are little more colored than whites. I don't know, that may be the reason. See, another thing is the amount of research done worldwide for vitiligo is actually very less, probably because it doesn't affect them so much. Maybe Indian will feel, but this is what I feel. The amount of research which went on for melanoma, even 1.5% is not there for vitiligo. So high time we Asians get up. We have got a lot of studies from Korea and China, and Japan, but not to match the research which is done in the West regarding some diseases. That's it.
Any other questions? Madam, maybe I have one question.
Yes, sir.
Usually for children who have jaundice, newborn period, we tell the parents to expose the sunlight before 10 a.m. And who are deficient of the vitamin D and all these things, 11 a.m. to 2 p.m. Just like that, you have any other?
Yes, we have.
For this?
Yes,
situation?
surely.
Yeah.
Actually, for the best effect, best pigmentation time is between 9 to 10. So we want the UVA rays. See, UVA is bright, maximum in the when the sun is in a slant, not risen up to midday. Midday is for vitamin D. But this rising sun and setting sun, these two times are excellent for vitiligo. So 9 to 10 and 3 to 4 would be ideal. So the UVA rays are the better ones, which can give pigmentation and tanning. People tend to tan a lot at that time compared to middle. Mid-afternoon, you will burn. You don't tan, you burn. This is the difference in response. Yes, good question. Now, sunscreens, patients come and ask us, you say sunscreens, where will we get your vitamin D? Where will we get health, skin health? Now, when we are usually using it on the face, this is not even 1% of this body surface area. So that makes no difference whether you have it on or not. If you were to apply sunscreen over your entire limbs, that would make a difference. Because there it comes to 11%, 11% each leg, 11%, 11% each upper leg. So total will be 22 plus another 22. 44% of the body surface area is required to get exposed to sunlight for you to get your vitamin D. So anyway, it doesn't make, we are all covered. It doesn't make much difference. So I tell patients they have to literally wear very small bit of clothing and sit in sunlight mid-afternoon for about 20 minutes to get their vitamin D. Otherwise, take the medicine.
Thank you very much. So nice of you. We thoroughly enjoyed it. I think same way after that, we're going to continue some of the environmental issues. This month is the plastic issue. Maybe next 10 minutes, I just want to sensitize the plastic related issue. Then we will definitely will like to felicitate Madam who has come here. The plastic pollution, unveiling the impact of the environmental and human well-being. Let's see. The World Environmental Day is celebrated on June 5th. Since 1972, under the United Nations General Assembly, this year's theme is Beat Plastic Pollution. And let's look into the plastic production. Humanity produces more than 430 million tons of plastic annually. In that, 280 million tons of short-lived plastic products, they become waste. 46% of waste is landfilled, 20% become a litter. It takes over 1,000 years to break down because it's non-degradable, non-biodegradable. Hence, it chokes marine wildlife and damages the soil, poisons groundwater and ill health, and microplastic deposits in placenta and breast milk also has been appreciated. Material is made from the fossil fuel. Crude oil generates nearly 1.8 billion metric tons of the greenhouse gases, 34% of the global total. If you look at that one, how the graph, how it is gone up from there to here, from 1950, it's gone up to 2010. We have so much, and by the end of this 2050, we are going to reach the top. It's going to go steadily high and high and high. Now, how does this nature trying to dispose this plastic waste? By 2050, we are going to produce that much amount. Nearly all the waste discarded is around this graph. This is the primary waste generated, and this is what it is. Not okay. Yes, that is the one. Second is all waste is incinerated. This is the second graph here. And all waste is recycled. This is the graph. And we produce 300 million tons of plastic waste annually. 1 million from the drinking bottles are sold per minute. And 5 trillion single-use plastic bags and the year. And utility of the single-use plastic waste, 36% for packaging of the food and all those things. 85% ended up in the landfills. I think today we got some message from near swimming pool area, somebody threw the food plastic. I think we have to wake up that. We should avoid that. And 60% material made into the clothing is from plastic from the fashion industry. 100 million pounds, that is nearly 4.5 crores nearly kg from industrial fishing. Microplastic are less than 5 millimeter in length in beauty. They are in beauty products. 6 lakh tons of microplastic from the laundering synthetic fabrics. For all producing all this is the list of the companies who are producing. That is ExxonMobil and Dow Industries and Reliance we have in the bottom here. We have to educate those industries to minimize the production. The plastic classification and what are the sources? There are two, phthalates and biphenyls. These are all the two things we have to be concerned. Phthalates are the most abundant industrial pollutant of the environment. They migrate to the surface of the plastic, either evaporate or leach into the surrounding area. What are the sources? The food packaging is the most common. Next, the food contamination, plastic toys, medical tubing, wall coverings, tablecloths, upholstery, and deodorant, insecticide, nail polish, and adhesive, etc. The bisphenol is used for production of the polycarbonate hard plastic and to make resins to line the metal and beverage cans. With heat, they leach into the source and adjacent material, water, food from the lining of the can. I think that's why plastic cup don't use coffee and tea. We have been recommending it. Yes, madam. Yes, the sources is food and beverage cans, gel capsule, cosmetic and flame retardants. The route of exposure, the phthalate leach into from the above products in a high concentration when they are heated. So that you are going to inhale that fumes by ingestion, skin absorption, as rightly pointed out, skin absorption, blood by intravenous route when you're using IV tubings and all this thing, transplacental from the maternal bisphenol A. Disease from plastic, what are the diseases we are going to have it? This is what one madam is covered half part of it. These are all the endocrine disrupting chemicals which affect the fetal and early postnatal development of the male reproductive tract. Predominantly it affects the undescended testes, hypospadiasis, decreased fertility rate, change in the immune system and inflammatory changes, acts as an antagonist for a thyroid hormone, behavioral changes, early puberty, adult onset diabetes, and cancer. So plastic pollution mechanism health is from the oxidative stress. Most of these oxidative, you also covered oxidative stress, air pollution, any other disease, all this is solar heating, all this come from the oxidative stress. And cytotoxicity, neurotoxicity, immune disruption involving the various vital organs were listed, they're all going to be affected from the microplastics. So this is the oxidative stress and various reactive oxygen series will be coming there. And we have, nature has got a balance. We have antioxidant. That is what is the antioxidant we have. We have hormone produced from the pineal gland. It protects the melatonin hormone. It protects us. What you have to do, nature needs only two things. You have a good night's sleep. Don't worry of anything. That's one thing. Have more of vegetarian food in your diet. That got more antioxidant. And I take a little wine once in a while, glass of wine. It has got little antioxidant. Red wine got little more antioxidant than the white wine. Because I'm taking, I have to cover it up a little bit. Taking a lighter wine. We don't recommend to the children, adults, what I mean. So nutrition and these are all the antioxidants we have to provide the nature. Have a good night's sleep. Have more of vegetarian diet in your diet. And impact is microplastic is small plastic pieces less than 5 mm size. They are equivalent to the sesame seed size. They are harmful to our lakes, ocean, and aquatic life. These sources are degradation of the larger plastic debris, exfoliants in health and beauty products, microbeads, cleaners, toothpaste, resin pellets to manufacture plastics, pass unchanged through waterways into the ocean. Fish and birds mistake them as the food. You can see how it is going up. The curve is going up. I think now it has to. That's why United States stopped it microbead free from water in 2015. They brought a law. So cigarette butts is a plastic pollutant. We asked to worry cigarette smoke only because that produces over 4,000 chemicals. Cigarette butt itself produces nearly about 165 chemicals. The most common contributor of plastic pollution globally, cigarette butts. And 4.5 trillion individual butts polluting our environment. 19% of adults smoked 5.6 trillion filtered cigarettes. 2017 expected to serve 9 trillion by 2025. Butts are, as I said, 165 types of toxic chemicals they have, like cellulose, acetate, lead, benzopyrene, styrene, whole lot of things. Their bioaccumulation affecting the humans and marine life takes about 10 years complete degradation. Cigarette butts. And if you see the ocean, what they remove all the waste, nearly 24.7% of the marine debris is related to cigarette butts. So the where people throw it out and goes rain in the drain and to the drain into the rivers into the ocean. And collection of this is what is started here in India, Noida. If they collect cigarette butts, if you collect about 1 kg, they give you 800 rupees. So people are doing waste collection thing. This is what Noida in our India is started. It's something welcoming measure. Cigarette butts as a plastic pollutant, the Central Pollution Control Number 1st 2022 guidelines. Cigarette butts are the pollutant, should be avoided. How do you do that? By recycling, end of life method by waste energy, co-processing, alternate plant-based filters, segregate as a dairy waste. I think alternate plant-based is we should not recommend that one because we aren't out tobacco smoke banning. We are recommending alternate thing, you use it. I think this doesn't hold good recommendation with Central Pollution Control Board. Anyway, I think India new plastic waste management rules came on July 1st, 1922, banned single-use plastic waste with the panel consequences. What are the things banned? Alternative, they have recommended in the picture: earbuds, plastic sticks and for balloons, plastic flags, plastic plates, cups, cutleries, trays and stirrers, straws, wrapping film around the gift boxes, invitation cards, cigarette packets, PVC banners less than 100 micron. These are all things they have banned. Anyway, World Environmental 2003, what are the slogan? I think last but one slide. Restore our earth. A lot of these slogans have come there for this year. Restore earth together for a sustainable future. Act now, save tomorrow. Green today, clean tomorrow. Our planet, our responsibility. Plant a tree, save a life. Let's make a change for a better planet. Recycling, the future is now. Reduce, reuse, recycle. Eco-friendly is the way to be. One earth, one chance. Let us save it. Be a hero and save your earth. Ladies and gentlemen, thank you very much. And also, I feel proud to say we have water conference about 2019. During that time, we awarded the plastic. We gave the water bottles for everybody. And recently, we had the Commonwealth countries ComHAD conference. There, we never used them. We used only degradable, all this thing. Plastic, we never used, only cups we used it. So we have been doing it on all these things. Anyway, let's award ourselves, our bit to this one. Anyway, thank you very much for your patient hearing. Over to Joshita. Okay.
Thank you, Dr. Parmesh. On behalf of the VECHA Center for Climate Change, I would like to thank Dr. Sumati for being with us here today. Thank you, ma'am. I request Professor J. Srinivasan to kindly hand over the memento to the speaker. Thank you, everyone, for being here today. Kindly join us for the photo session.